So welcome to my presentation around improving the outcomes of adolescents with health needs through collaboration. A little bit about myself. I have an adolescent son who was diagnosed with a long-term health condition in 2016. And obviously, it was a complete shock to the family. And at first, we were totally focused on meeting his physical needs and just to, keep him alive and keep him well. But then at some point, we realized that it takes more than that. So other than just meeting his physical needs, we had to shift to a more holistic approach to meet all of his needs and, well, to keep him well. And so in the course, on this journey, I have had to talk to various schools and healthcare professionals. And I was kind of asking myself, do schools know what parents know? Do healthcare providers know what schools know? And also, do schools know what healthcare providers know? And I was unsure whether, there was any information going between these parties. So a little bit to the context of my research. Currently, there is 1 in 5 adolescents in the UK living with a long-term health condition. This is just one estimate of the Office for National Statistics. There are various estimates, but basically what we can safely say is that every single school would have several of these young people to support. Research shows, unfortunately, that schools fail to support this population. We know from Michael Marmot that education is an important social determinant of health, while physical and mental health during adolescence are key for educational and vocational outcomes. Previous research identified a number of risk factors linked with poor health during adolescence, such as psychosocial risks, school absences, reduced educational outcomes, and an increased likelihood to end up not in education, employment, or training after the age of 19. Some of the barriers identified by previous literature include schools' use of the medical model instead of the socioeconomical model. And basically, what it means is, the medical model attributes problems to internal factors without taking the environment into consideration. The socio-ecological model considers health to be a state of well-being and not merely the absence of an illness. So health is linked with the environment, and supporting environments are based on this positive understanding of health. The sociological approach to health highlights the importance of connectedness, of mental well-being, and psychological risk factors such as isolation, as well as environmental risk factors such as, for instance, the socioeconomic status to health. There is a lack of empowerment within this population. These students seem to keep their head low, not ask for support. Families often don't ask for support and they don't know what support they can get. There's plenty of legislation to protect the rights of these pupils, but there's absolutely no monitoring on any level. And the lack of coordination between health and education is also a recurring theme in the relevant literature. And that's around policies, as well as around goal setting. So for instance, in education, we work with children, young people from 0 to 25. Health mostly works with them from 0 to 18. And we know that the age of 18 is such a crunch time where young people finish school, become independent, become financially independent, start the university, move away from their families, start a job. And so our population, in the midst of all this, they then have to switch to adult services as well that can be very different from children's services. And all this is just really hard to manage, and it's really easy to go lost in the system. So why does adolescent health matter? The World Health Organization found that there are no targeted interventions to promote health in this age group. This is the invisible generation in terms of health promotion. At the same time, this is the age where really important foundation is laid for well-being during later in life. Physical, cognitive, emotional, and social foundation for health. This is the age group that's, they're the next age group to parent, which means that they define trajectories into the next generation. And so their health has really far-reaching implications for generations to come. My research question was, how can health and education services work together to improve processes around adolescents with chronic, life-threatening, and life-shortening health-related conditions? I had 5 subsidiary research questions exploring policies, guidance, and legislation, transition and inclusion, the awareness of educators, interaction between different agencies, and social, emotional, and mental health needs. So, and then this happened. So I got my ethics approval in the week of March 16, 2020, the week of the first school lockdown. And obviously, just like the rest of the world, I was completely shocked. And I thought, I can't continue with this, because how can you do research in schools and about health during COVID? But then after the first shock, like everyone else, I also learned how to use Zoom and Microsoft Teams. And I started to consider, that maybe it's okay, maybe I can do it. And I just need to think about how to move things online. Obviously, no more recruitment through schools was possible. So I received support from the School and Public Health Nurses Association, who kindly shared my research on their social media sites. I contacted charities, and also my participants helped me with some snowballing, so they recommended other participants, etc. And it worked. I made it work, and it worked. So my participants were, I had 36 school nurses for a quantitative survey that was used to develop the themes for the qualitative interviews. I interviewed 8 school nurses, 6 young persons, and a parent. These were joint interviews, and it was the mother each time, and 5 educators. Now, I would like to tell you a little bit about my young people, because they are so important for this piece of research. So I had a young person with arthritis, 2 with cystic fibrosis, 1 with epilepsy and additional learning needs. That was my only participant with additional learning needs. 1 with type 1 diabetes, and 1 with narcolepsy cataplexy. So all 6 of them attend secondary schools in England, and all 6 of them had very poor experiences in school, and they had support that they found was lacking. As for my methodology, so I developed a quantitative survey for the school nurses and based my semi-structured interviews on that survey. I interviewed all participant groups and used reflexive thematic analysis to generate themes. And these are my key findings. These are my key themes, actually. So as you see, there are a number of shared themes where different participant groups address the same theme, but from different angles. And I'm going to tell you a little bit about this later. But the one theme that they all highlighted is communication, and namely mostly the lack thereof. So there seems to be very little communication between schools and healthcare services, little communication within schools, from desk to individual teachers, or from senior leadership team to individual teachers, little communication from school to parent, from school to pupil, and generally a lack of information flow. The lack of scrutiny and the lack of monitoring was highlighted by various participant groups. The lack of awareness for invisible needs linked with learning needs, and these would be, the social, emotional, mental health needs. Not linked with learning needs, linked with physical needs. Learning needs and social, emotional, mental health needs linked with physical needs. There's a lack of awareness, and because of that, also a lack of support. There are a lot of expectations on schools to meet needs, and they are in a difficult situation for a number of reasons, as we know. Health representation in schools was, of course, mentioned several times. unfortunately also mostly the lack thereof. So when there is a school nurse in schools, things tend to look better, but unfortunately that wasn't the case very often. So then back to my individual question, to my initial questions: do schools know what parents know, and do healthcare providers know what schools know? In a nutshell, the answer is no. So there is a lack of communication, as I mentioned. There is a lack of participation. Pupils and their parents are not invited to support planning procedures. They can't share their views and their desires, and they are just not part of the support that's put in place. And unfortunately, because of the lack of transparency of these support systems, they often don't know that there is support put in place for them. And if there is support put in place, what that support looks like. They don't know who to talk to, who they can address with their questions, who can support them. There is a lack of alignment of goals between schools and health. Namely, often schools see education as a zero-sum game. So health needs are seen as a burden on the teacher rather than good health being the product of quality education. Health takes time away from education. And there is a lack of awareness of invisible needs, such as mental health needs and learning needs. So a little bit more to the communication, information share, just to explore this theme a little bit more. 86% of the school nurses noted that schools have a named medical lead, which is a statutory requirement, to have a named person in school to implement medical policies. 5 of my adolescents did not know that whether there was a medical need, and 1 thought that there was one. 67% of the nurses noted that schools have a medical policy on their website. Again, 5 didn't know, and 1 knew that they didn't have one. School nurses, about 5% of the school nurses always include pupils in training. 19% include parents, and 29% include healthcare professionals, which, in itself, these numbers are problematic because they should absolutely be included always. If they are not physically present, then at least their views need to be included. But out of my participants, not one was invited to school to contribute to training, and they were not aware whether their healthcare professionals were invited. And I don't know if you remember, but some of the conditions, these participants, they were rare conditions like narcolepsy, cataplexy, cystic fibrosis. These are not conditions that schools would typically support. So it was just a little bit surprising that they were not invited to contribute to training. And so you really wonder what goes wrong here, because school nurses are under the impression that things are happening, yet families report that they are not happening. So where is the crack in the system? Where is the bit that goes lost? And this is a quote from one of the participants with arthritis. It's the parent actually of the young person with arthritis. There just seems a bit of a lack of communication because we don't actually know who to address with her problems. And that was symptomatic for all of my participants. Now, further to the communication, the information share, as I mentioned before, without the school nurse on site, parents don't know whom to address with their questions and issues. There's a lack of transparency of support systems. It is not clear to families, who is supporting and how they are supporting. Information does not drip down to individual teachers, which unfortunately results in situations like a medical absence is reported beforehand, but the information is not passed on to individual teachers, which means that one of my students, while he was in hospital, got a behavior point for work that was not completed during the lesson. And of course, the behavior point can be cancelled later. But it was a very upsetting situation for him because he was already unwell and he was already in hospital and not happy about all this. And then he got a behavior point as well. And he was not the only one of my participants who reported of punishment because of missed work. So again, I think that this is about information share. Schools, these pupils arrive back in school after an extended absence, they don't know what work they were meant to complete because work was not sent home, but then they're getting punishments for missed work. The progress is not monitored in any way. The data is not scrutinized on any level, not on school level, local authority level, national level. And schools don't have to communicate it, and they are not held accountable. And we know the pressures that schools are under and all the different needs that they support. And frankly, this is an easy one to tick because illness, they're not in school because they're ill, they're not doing well because they're ill. So, let's move on to the next population. What works in terms of communication is transitions from primary school to secondary school. There generally seems to be a good chat, and plans are passed on to secondary schools. And also, in case there is a new diagnosis, schools listen to parents, and they try to understand how to support these pupils. What really doesn't work is transition from specialized settings, for instance, from hospital schools to mainstream schools. There just doesn't seem to be anyone responsible for that. It is the responsibility of the mainstream school to provide keep up and catch up support, to ensure graduated re-entry, but it's just not happening. These are again 2 quotes from 2 of my participants. A school nurse says, this is also regarding absences, not really keeping them integrated. They do things like sending homework home and things like that. But in terms of socially, I do not really think they are. And my young person with cystic fibrosis, we asked the school for work from every lesson I would miss out on, but not every teacher gave me work, but then I would get punishments for missing out. It seems that during absences, there are absolutely no efforts for social integration. These students are out of sight, out of mind. And with some of these conditions, there are a lot of absences. There are seasonal absences, for instance, with cystic fibrosis. There are medical appointments. And even when they are in school, they might be missing chunks of the day because, for example, with narcolepsy, they might need a nap. They might need to go and cough. They might need to treat their blood glucose. So there are a lot of absences. There's a lot of chasing for parents to get any work. And whatever work is then sent home is not differentiated for these students. So for instance, they would be sent a PowerPoint presentation where they didn't know what happened in the lesson, in the previous lesson, in the lesson after that one. And they are meant to watch a PowerPoint presentation while they are unwell, while they are working in isolation, and then they go back to school and they are meant to know what was discussed. Upon re-entry, there's no support provided for catch-up, and for catch-up, usually it's ask the person sitting next to you if you have any questions. And sometimes there are individual teachers. Absolutely, there are individual teachers who reach out and who do provide this support, but there is no systemic approach. So it's down to individual relationships and individual teachers. So some of the, some risk and protective factors were identified based on these interviews. The environment, if there is support in place for physical needs, when there is enough awareness in schools, when there are, teachers with a good awareness, then the environment is a protective factor. And when all this is missing, then the environment soon becomes a risk factor for these young people. A trusting relationship with an adult or with peers is a strong protective factor. School absences are a great risk factor. Communication, collaboration, again, when it's in place, it's a protective factor. When not, it's a risk factor. And then individual factors such as resilience, the ability to self-advocate, independent learning skills, when these are present, then these are protective factors, and when not, it's a risk factor. So some key themes for reflection. For schools, it is really just raising the profile of this population, just having more awareness around needs linked with long-term health conditions. there needs to be early intervention. So as soon as attendance drops, levels drop, there needs to be an intervention. It needs to be explored what the reason is. Is attendance dropping because the young person is really unwell? Or is it dropping because of mental health needs, because of a badly managed condition, that then leads to an absence? It needs to be explored. The reason needs to be explored and not just ticked off with the illness, because obviously it would all require a different approach to improve attendance. They need to consider interventions around self-advocacy. How can we help adolescents to have a better awareness of their needs and to talk about it, to ask for support? And that's not just for this population. There are a lot of adolescents who don't want to speak out and, who need support with this. We need to help them do that. There needs to be more transparency around support systems, and they need to unpick absences. So for healthcare professionals, they need to start aligning goals with schools. They need to include schools when they support young people. And particularly when they support rare conditions, they need to link with schools' medical lead. They might not have the capacity to do it for every child with asthma or, one of these frequent conditions. But when they support young persons with rare conditions, it's really essential to find out what needs to be in place in school to discuss that, and just to, have a joint up goals. And a good example for this would be the epilepsy passport, which was developed by healthcare professionals to raise awareness around needs and support specifically for epilepsy. But it was developed without the inclusion of, any educators, any schools, and it became really medicalized and something that schools don't really understand and find difficult to work with. So it would be really helpful to include teachers for these projects. And yes, healthcare professionals need to be more involved with health promotion within schools, in terms of moving away from lecture-like health promotion, and just to support schools in continuing to promote health and increasing health literacy. For EPs, we need to continue with consultations and conversations to unpick individual needs. We need to organize knowledge exchange, within our clusters or within our geographical area, between medical leads, the same way we do for SENCOs, just to exchange good practice, what works and what doesn't in terms of support for this population. We need to raise the profile of this population. We need to support schools with interventions around self-advocacy and independence for adolescents. It's really crucial. And we need to provide training. And I don't mean training to support medical needs, because, EPs are not the right people for that. But in finding out what creates a barrier, so unpicking mental health needs and learning needs from the physical needs. So if there are a lot of absences, there will be learning needs. So how can we support those? So we need to support schools in, exploring these needs. So this is a quote from one of the medical leads from one of the schools that I interviewed. What kind of support? And it's interesting. The diabetes nurse thinks they need, the child thinks they need, and the parent thinks they need. And I think this is really crucial for our consultations and conversations, because the statutory guidance says that there needs to be appropriate support in place, but it's not defined. So when we start working with these families, or when we start working with schools supporting these families, it's really important to define what's appropriate support within a school. And that needs to be monitored and reviewed regularly. We need to explore attendance issues. Schools need to be on it. And in planning meetings, the same way we raise awareness for different vulnerable populations, we need to start raising awareness for this population. So ask targeted questions about this population, questions about named person, medical policy, individual healthcare plans. All this is in the statutory guidance, and we can't police schools, with the statutory guidance. We can just, raise awareness, ask questions. On an organizational level, schools need to make the journey from physical needs to a more holistic approach, see more in that young person than their illness and see what other support they might need. Again, knowledge exchange to understand good practice, advocacy for this population, interventions around self-advocacy, and harnessing peer power. And I think if I restarted my research, that would be the point that I would focus on, because it's crucial. Because when there is peer support in place and there is a good awareness among peers in place, it makes all the difference. And we really need to think about how we can do that, while at the same time respecting, of course, individual rights and the willingness to share and all of that. How can we harness peer power? And on a local authority level, we need to explore training opportunities around the impact of physical needs for school staff. We need to continuously assess practice of schools and collect data on outcomes. And we need to continue supporting schools, to meet mental health needs. And so what? So EPs can draw attention to this group to ensure that they remain visible and monitored, and that their emerging problems are identified early on. EPs can also support schools to separate learning and mental health needs from physical needs. We can upskill schools to identify and support mental health needs. We can advocate for policy coordination. And we know that for all adolescents, not just for this population, but for all adolescents, communication skills, self-advocacy skills, and the knowledge of their own needs and rights are necessary to become educated voters and decision makers on the future. And this all begins in school. And so to reframe the pandemic, which has been so hard, but it highlighted the important role schools play in health management. We now understand the interconnectedness of schools and health. It introduced strategies for health promotion, hand washing, etc. Don't come to school when you're not well. All students during the pandemic had to work in isolation, and all students worked with concerns about health, maybe their own health, maybe other people's health, or maybe just general concerns about the pandemic. And all students needed a graduated return. And so we now see that returning to school after an extended absence, it needs planning, and it needs more than just academic catch-up. If we look at the recovery plans of schools, if we look at current mental health needs in schools, we see that it's more than just catching up these kids who have missed out on education. It's much more than that. And so hopefully this knowledge will contribute to the future support of the population that I'm talking about. And so briefly back to Michael Marmot and health inequalities. Again, I would just like to highlight the bidirectional relationship between health and education. Marmot calls for a doubling of healthcare spending over the next 5 years to tackle and prevent inequalities and growing problems such as homelessness, low educational attainment, unemployment, and poverty. So I haven't talked about funding, because funding is not something that we can change so easily. And I think that there are things that we can change, such as communication, but it's not the only factor, but it is a really major factor that's required for making a difference. So I understand that. And, if we improve funding for health, then this is going to have an impact on education as well, hopefully. And these are my references. And, now is the time for questions. And I also wanted to encourage you to get in touch. This is my email address. It's my Twitter handle. And I wanted to tell you a little bit about a small research group that I'm contributing to, or I'm a member of. Perhaps some of you saw Lauren's presentation a couple of weeks ago around chronic pain. There's another colleague who, another newly qualified EP whose research was around chronic fatigue in schools, and another colleague who explored pupils' views with chronic health conditions. So we are hoping to disseminate research together and hoping to put something together, a special issue, or I don't know, a blog, something like that, that will hopefully come handy to some of you. And so I guess now is the time for questions, if you have any. I don't see any open questions right now, so maybe I'll just wait a minute. I see that, okay, I see the chat, just not the questions. Okay, so a hospital school teacher, please check out. Okay. Oh yeah, Robots in Schools project to support people. Yes, it's brilliant. The robots in schools are brilliant. And you know, when there is funding and when that's in place, I don't know if you're familiar with that project, all of you, that's really, really great. Unfortunately, it's not very easy to get. And thank you for the link that you sent. Would include in reflection, ensuring collaboration with young person and family completely. It is, first of all, it's a legal requirement to include young people and families in the support planning procedures. And yes, it's just so important, because if we don't know their views, then how do we support them? Right, we have, okay, so this is part of a series. We have Sarah in November to talk to us about her research around school experiences of children with chronic health conditions. Yes, so she's another one of my, another member of my little group. We are a hospital school in Oxford, and we feel a lot more positive work has gone in this area than your research suggests. Okay, thank you for this, and I would be really happy to talk about it. And okay, key learning about what good communications between healthcare providers, young people, teaching staff look like, and good example of what works well. So my participants said that when it came from health, it usually worked better. So when healthcare providers reached out to schools, then there was more openness. And I think, you know, a really important for teaching staff, a really important part of the conversation is to break it down, to see what needs exactly look like in schools, what they present like, and you know, how they can be supported. So I guess this is the key learning. It should come from health, and it should be broken down into language that's understandable in schools, and into, you know, presentation in schools on a day-to-day basis. Very pleased to know you have researched this area, highlighting the need for EP involvement. Thank you. Okay. Did your work explore improving documentation, electronic records such as shared? Well, so I did, some of my questions were around shared individual healthcare plans. Some schools still use these for you know, the same for students who have the same condition. It's not really good practice, because it takes away you know, individual experiences. So I guess you know, if you use a shared document, for example, for asthma or for epilepsy, you know, these conditions, it's really important that you don't have it for the group, but even if it's a shared document, have a, you know, have a box or have a page where you describe individual presentations and individual experiences. An individual shared document. Yeah, so I'm not sure. Yeah, a key challenge is availability of health professionals to join meetings, especially the mental health rather than physical health needs. Absolutely, there is. I think that is key. But you know, I found that even when there was no you know, when the healthcare consultant wasn't involved, you know, there was maybe a nurse or there was like a diabetes educator, or someone with good knowledge of the condition who was able to support schools. So you might not find that the actual consultant is available, but hopefully there is someone on the team who is. Medical needs in schools projects. Yes, it's the Alliance. I have tried to reach out to the medical needs to the Health Alliance working on this project. I have not yet received any answer, but hopefully we can be in touch now. Some school nurse teams are employing a SEND school nurse. They could be an advocate for the family and a bridge between health and education. In special school nurses, there are often nurses on site to provide support. Yes. Yes to both of these. Right. Okay. So I think maybe this can be the end of my presentation. Oh, there is one more question, maybe in the Q&A bit. SENCOs would be really unlikely to think to refer to an EP for support around children, young people's absence is connected to a significant medical condition, much more likely to reach out to health professionals in the first instance. So perhaps a flow diagram to encourage a wider net. Pupils' voice and more joined up solutions. That is a great idea. Thank you very much, Imogen, and I'll take a note of that. That's true. I think it's true. SENCOs would be really unlikely to refer to an EP, but I think that's why it would be important to just, at planning meeting, to highlight this, that when attendance drops and when levels drop, you might not refer to an EP straight away, but you need to explore this in terms of learning needs, mental health needs, and any related needs, and maybe EP's role can be seen in just raising awareness for that. So I had okay. I had someone from a hospital school. I had specialist advisory teachers. And I had a teacher from a school who had the role of being the medical lead. Okay, I think I will stop sharing now. And thank you very much for your time today. And thank you for being here. And I'm looking forward to maybe hearing from some of you later on. So thank you.